Hello, my name is Dr. Porter McRoberts. With me today is Dr. Paul Wu, my partner and esteemed colleague.
Thank you.
We are both interventional physiatrists in South Florida here. So we're talking about something that I don't think really anyone's talked about on YouTube or the internet, and it's something that we don't talk about a lot, but it's something we have to, and that is what happens when things don't work. And it does happen. There are times when patients come in and we may try something and we don't get any relief. And I'm sure you've had a lot of patients come to you who may have had multiple epidurals with other physicians, etc., and really quite saddened with the situation, thinking that there's nothing else that can be done, and concerned that they're going to be stuck in this precarious position. So let's say someone comes in, Dr. Wu, and they've had a facet joint nerve block and facet joint nerve ablation, and they had their hopes up, but for some reason they did not get the relief they were looking for. What's your approach after that?
Well, I mean, I think it'll still come back to going back to square one, to the drawing board. If there's a new patient come to me, I still go through, knowing all those information, I still go through the same thing, take my history, listen to what patient had to say, analyze the history, what could be possible, the pain generated based on the history, do examination to confirm that. And typically, there's always something that in my mind, there's maybe something has not been tried, or there's maybe something else. Depending on what I found in examination, I certainly will consider looking at the MRI or other testing. Sometimes even send for nerve testing. And I certainly have patient. A case example, I have a patient who had hip replacement and was keep complaining to me that that there's no unable to lift their hip, and everybody's been attributing that to this is a hip replacement. Went to see a surgeon. Surgeon said the hip looks fine, and I look at the X-ray. The X-ray does look pretty good, but at the same time, it doesn't. You can't really neglect the patient's symptom.
Of course.
So look at MRI. Really wasn't. There's some this problem. Did the epidural injection, did not help. Still the same issue, and talking further, I mean, it's really not the pain, it's the weakness. All right, sometimes it takes a while for a patient to verbalize that, and examination you always have has some mild weakness. So eventually, we actually did a nerve study, and finally, actually, our patient has syrinx, all right, which is a dilatation of the spinal cord. So those are things. Those of course that's a fairly different case in terms of what we talk about, but the point is that we always go by the drawing board and figure out what else can be done.
Yeah, I agree. Just because the first thing or sometimes even the second or third thing doesn't work doesn't mean that the game is over. It just means that it's getting a little more interesting, and that we have to delve a little deeper and maybe order some specialized tests and maybe look at some blood work, get different types of views on MRI, maybe call in something like physical therapy, look at the myofascial component of pain, maybe even get a surgical consultation. But you and I both, our first aim is to really try and isolate the cause of the pain. I think that's the first thing we have to do in any situation. Secondarily, the second phase is really trying to treat people who have the pain, irregardless of the source. And even though one hand is trying to figure out what's going on, the other hand is also trying to treat the pain despite what the left hand is doing. So it's very, very important, but I guess the take home for our patients is, even though we haven't gotten around the first or second try, does not mean that we're not going to stop trying. That's, I think, maybe one of our strengths here is that we don't give up too easily. And I've known both of us to get really quite deep into patient care, spending months, if not years sometimes, on patients who've been all over the world seeking answers. And personally, as I said to our staff when we started, I said, we're going to have some failures, and then we're going to have some successes, but those successes will be incredibly sweet, because often they will have seen multiple other physicians, and we get to be the one who hits the ball out of the park, and it's incredibly satisfying.
Right, and also like sometimes, that when something doesn't work, it doesn't necessarily mean it doesn't work. For instance, you have a facet joint ablation, which is commonly done, and patient will often tell me, and this happens, very frequently, is that the pain is a little bit different now. Okay, the pain, patient come back for follow-up and tell me, doc, Dr. Wu, this is, I had this ablation, it doesn't work at all, and et cetera. And you talk a little bit, and then so is there any difference in terms of your pain pattern? It's pain, so where's the pain now? And of course they show now the pain is actually in the hip, now the pain is in the bursar area. And so, is this different than before, you say? And then think about it, and they say, yeah, this is different. I mean, before the pain seemed to be more in the back, but now it seems to be in the other area. Or when I walk, I have pain, and you palpate around the iliac crest, you have pain. And so, I mean, and of course, once you further diagnosis, I mean, it almost sounds like a kind of bursitis, a proximal gluteal tendinopathy, and for that, a single trigger point sometimes helps, or even just prototherapy.
Absolutely.
And so the whole point is that I tell patient that as long as you don't give up, I don't give up. But once you give up, it becomes more harder for me to to try to encourage you while trying to diagnose the problem at the same time. And that goes back to our treatment philosophy is that when patient comes, I mean, we really want to focus on what is a pain generator, how we can treat it. It might not be a home run right away, but and we have patients come back time after time, and I think we both have records where it shows that we are actually able to figure out things out just by go back to drawing board step by step, trying to figure out what else is wrong.
That's a good point. Sometimes just figuring things out is a very important thing.
Right.
For example, knee pain after having a knee replacement.
Mm-hmm.
I have a lot of patients who come and say, well, I saw my doctor and he said there's nothing wrong with the knee, and then we go to the back and we may do a quite extensive workup, but what we also do is rule out things that are scary. Rule out cancer, rule out pinched nerves, rule out paralysis causing complications. We systematically go through and make sure that there's no infection, there's no malalignment of the hardware, etc. And even though the pain may be still there, and we're going to continue on still trying, sequentially I think what we also do is relieve people. Relieve their anxiety about what's going on, knowing that they don't have sciatica, knowing that they don't have a bad back, knowing that they're safe in terms of their ambulation. It may hurt a little bit, but they're safe to walk. They're not going to become paralyzed. And really dial in the diagnosis down to the most discrete variables that remain, and then try and find a sometimes very creative approach to treating the pain.
Right, and I think one important thing throughout all this is actually, I keep emphasizing to the patient that this is actually teamwork.
Absolutely.
This is a team, not just our team for us, the care in the clinic, but actually a therapeutic teamwork between the patient and us. And a lot of times I think it's good for us. It's a very humbling experience.
That's true.
You kind of sometimes you wonder, the body is just so complex in terms of even what we typically say is musculoskeletal. It can be very hard, but in reality is.
I tell you what, it is hard to get a big head in this line of work.
That's
you
right.
will be humbled every day.
That's right.
Well, I guess the takeaway for us is that even though we haven't hit the ball over the fence on the first go, please don't give up. It doesn't mean we're going to stop trying. It doesn't mean that we're not going to find the answer. It just means we've got to try a little harder, return to the basics, do a good exam, really listen to the patient, and hopefully through good teamwork, try and figure things out.
And we're treating you, we're treating patient, and that's always been our main objective is the patient.
Thanks.
All right.